Welcome back to my channel. My name is Khadijat Adeshola, and in my channel I talk about everything related to midwifery, women, migration, and all of that. So if today is your first time coming across to my channel, thank you. Try as much as possible to watch this video if it's something you are interested in. And of course, if you like the video, please try to give the video a like and also share to your colleagues and friends that might benefit from this video, especially if you are a midwife. So in this video, I'm going to share my day. I'm going to be sharing how it is like working in the antenatal ward as a midwife, how the day is, a typical day in the antenatal ward as a midwife. So kindly stick around and watch till the end, and don't forget to subscribe to my channel because I'm going to be posting lots of information relating to this in my channel. And also don't forget to share with your colleagues and friends that might benefit from it. If you are my returning subscriber, thank you. I really appreciate you for always watching my video and also always coming back to watch my video. Thank you. So basically, typical day in the antenatal ward. How does it feel like? And can I tell you that antenatal ward in England is one of the busiest ward anyway that you can work with. So basically, depending on the hospital you're working with or depending on the trust, most of the time in the antenatal ward is usually one midwife to 8 or 9 ladies or 8 or 9 women basically. So when you come into the ward in the morning, there are usually, I think, 3 types of shifts. Is it 3? There is long day. There are different types of shifts in NHS anyway, depending on your situation and depending on the kind of, your ethnic and all of that. There is long day. We start at 7 a.m. to 7:30 p.m. and there is early shift. We start at 7:30 a.m. to 2:50 p.m. and there is late shift which start at 1:30 p.m. to 9 p.m. right? And there is late night which start at 9 p.m. to 7:30, 7 or 7:30 in the morning. And also there is some morning shift as well that start at 8 a.m. and some that start at 9 a.m. depending on your need. So most of the time those shifts are for people that have to drop their kids in school in the morning. So you definitely need to speak with your manager the kind of shifts that will be beneficial to you anyway. So most of the time when you come, the handover is usually in the morning. That's 7. Handover starts from 7 a.m. to 7:30 basically, but depending on what's basically going on, sometimes handover will not make me get to like 7:40, 7:45, 7:50, depending on what the situation is and when you actually start the handover. So let's say typically handover starts by 7 in the morning. So all the midwives that done nights will definitely hand over, and most of the time they in the antenatal ward they actually print an handover sheet which they share to all the people coming for the shift. So including the MCAs, everyone gets the handover sheet, and the midwives are working the night handover to you. So basically, I'm talking about the day shift. So if you watch this video and you will want me to talk about what happened at night in the antenatal ward, please say that in the comment section. Or you want me to talk about anything related to midwifery in a video, please also say it in the comment section and I'm going to grant it anyway. So in the antenatal ward, after the handover in the morning, we started from 7 and ideally should to end by 7:30. There's actually always a midwife in charge of a shift, of each shift. So the midwife in charge will share everyone to where they should work we're in. So most of the time, antenatal ward usually have over 28 beds. So there will be one midwife to, to like 8 patients or 9 patients, depending on what it is. So three midwives basically, and there will be, sometimes student midwives will be on shift as well, which they will added to each of them. And of time there might be midwife on supernumerary, which will also be added to someone. Basically, I said it, you can watch my previous video on supernumerary or preceptorship, basically, because the supernumerary midwife are not in number, so they will be attached to one other midwife, basically. So after that, everyone goes to their day. After the midwife in charge, share each and every one of us to where we'll be working, then we go to our bay. The first thing we do is that there's usually a sheet in front, in our bay that usually talk about the beds and what you need to do during the day shift. So it's number 7, 8, 7 a.m., 8 a.m., 12, 9 till the end of the shift. And there is a space for the bed number. So if you're working in bed 1 to 8 now, you just put it there, 1, 2, 3. If you're working in the middle side, which is like 5, 6, you basically put the bed number and the activities you need to do. So first thing we do is to put when they are due for FH. Usually FH is done 4 hourly, every 4 hourly. So you put when they are due for FH to know what you basically need to do. So you just continue from what has been happening in the night, basically. So if the last FH was like 6 o'clock, so that person will be due by 10. If it's like 5:30, that person will be due by 9:30. So all of those things, you put it there. Then in 8 a.m. you do your drug round. So drug round, you check through the system if anyone is on regular medication, if anyone is due for any medication, and of course pain relief are usually PRN. So most of the time ladies ask for their pain relief whenever they feel pain. It's usually PRN, basically. Now, what most of the things that happen in antenatal ward, they are basically induction. About 60 to 70% of inductions usually happen in the antenatal ward. So, for early labor, they transfer them to the antenatal ward. So basically, most ladies are on induction or we start induction. So you check when was the person that handover will have tell you when they start their induction. So the induction process, basically they use the propers and prostin, basically. So propers stay in there. Propers is like a pastry, so you stay in there for 24 hours. So you want to check when did the person start the process. Was there, is it up to 24 hours? Do the process needs to come out and none of that? Then of course, you check which of those ladies need CTG and which of them is a priority for CTG. So most of the time, people on induction of labor will have PDCTG, but people admitted for like maybe PV bleeds, PV bleeds will also have like BDCTG. But people like, let me say, people that really do not really have, for instance now, ladies with pregnancy less than 26 weeks cannot have CTG. They can only have 4 hourly FH. So you listen to their baby every 4 hourly, and you also serve their medication. So that's what you do for that person. But everyone on induction, the standard is to do like BDCTG, but some of them end up having like 3 CTG or 4 CTG daily, depending, because at any point they complain of pain during induction, you will have to put them on CTG. So most of them end up having more than 2 CTG daily. Any women admitted for PV bleeds, anything like that, in as much as they have more than 30 and 26 weeks, they have to have BDCTG. Then at times, some people, the plan may be for them to have once daily CTG. So people on BD CTG, most of the time they will have the 2 CTG during the day shift. Yeah, during the 12-hour shift. Most of the time they have the BD CTG, because you do one maybe around that 1, 12, 10, depending on what it is. And by 6 p.m. you might want to do another CTG as well to make it 2. So everyone on BD CTG, most of the time have the 2 CTG during the day shift. Now, people on daily CTG, most of the time they have it during the night shift. Very early in the morning, like 6 a.m., they might have their CTG. So there are some reasons why CTG might be repeated to be like 3, 4, 5, depending on what is happening anyway. So your trust will basically have policy for all of those things. So most of the time, if the CTG do not meet criteria on just regiment, you might not know what that is, but basically in your trust, if you are reading all of those things, you do it. So most of the time you repeat CTG. So depending on the situation, some people might end up having like 4 CTG, 5 CTG. You might end up calling the doctor to come and review a CTG kind of. So most of the time things just keep happening, and before the end of the day you find out that it's not gone for break anyway. So it's usually busy. So what we do is basically listen to FH, serve medication, and do CTG, and also start induction. So that is what happened in the antenatal ward, and this process continue. So why make it busy is that during your CTG, you might find a lot of things, that you really need to heart on. For instance, there might be, the woman might be one of the most side effects or complication of, any of those induction process is hyperstimulation of the uterus. So after having an induction agent, the propess or the prostate, women might be contracting, like more than 5 in 10, 6 in 10. And the policy says in my trust that once they are contracting more than 5 in 10, you should take the propers out, basically. So all of those things are like emergency, and that is why as a midwife you should know what is normal and what is abnormal. And when you notice anything abnormal, you should be able to quickly, initiate the appropriate action. You call the doctors, you tell the senior midwife. Basically we say tell the senior midwife, tell the senior midwife. Most of the time in the world, in reality, the senior midwife is extremely busy as well. So you should be able to know how to call the doctor, how to call the registrar, how to call the obstetrician. So when you call, you basically, tell the midwife what you've done or what you're about to do. But most of the time, the senior midwife will not do it for you, but you need to inform the senior midwife. So the senior midwife will be able to communicate everything that is happening to the other ward managers, basically. So that is how it works in the antenatal ward. And basically, I can say is that antenatal ward is one of the busiest ward in maternity. Antenatal ward, delivery suites, triage, they are actually busy. So you should basically know when to call for additional action, additional help. And one of the concerns you can have in antenatal ward is basically on CTG. So when woman is contracting too much, they complain of pain, the first thing you do is you ask them about the baby movement. You ask them if they've actually, seen water, if there's any strom, if there's any PV bleed, and all of that as well. You still put them on CTG. So after putting them on CTG, you go tell the senior midwife, and also you call the obstetrician or the registrar, obstetric registrar. You call them to come and have a review of the patient. So if the patient is on, is on induction and the last VE is over 6 hours or something, or you think the contraction is too much, you can offer a VE. After offering a VE, of course, the finding as well. The finding and the time, you document it, and also you tell the senior midwife in charge of the ward. who will then communicate to the delivery suite, especially if the woman is now in active labor, so the person will need to be transferred to delivery suite. If the woman now need an emergency care, the person will be transferred to the delivery suite. Basically, that's what happened in my, in my trust. It may be it's somehow similar in other trusts or different. So you need to check what happens in your ward or in your trust. But basically, that's the routine of what they do in the antenatal ward. So in some trust, when you see that in some trust, when there's a past stimulation, they can actually offer tabutanin in the antenatal ward. And in some trust, you can't give tabutanin in the antenatal ward. They have to transfer to delivery suite. In some trust, midwife can give tabutanin. In some trust, midwife cannot give tabutanin for hyperstimulation of the uterus. So you basically need to know what happens in your trust and be familiar with your trust policies and guidelines. Yeah, basically familiar with your trust policy, familiar with the NICE guidelines. Most of the time, some trusts do not really rigidly follow NICE guidelines. So most of the time, some trusts do. Some trusts, most of the trusts, all trusts definitely have their own policies. So make sure you are familiar with what is applicable in your hospital and in your trust. And if you have any question, always ask your senior midwife or your colleagues that have been working there before you. Basically, if you have any question regarding this video, say that in the comment section. If you enjoy it as well, don't forget to give it a thumbs up and a like, and also subscribe to my channel. Thank you for watching my video. Bye.